Loud and clear?
Yeah.
Excellent. Welcome everyone to a fantastic session. Let's start the countdown and let everyone in.
Welcome to Paris. Just look at this. The Optica Industry Summit on Aerospace and Defense will happen here at Saint-Léger Castle, AX Campus's castle in Saint-Germain-en-Laye, in Paris. In an event hosted by Exile, we bring together the who is who of defense, aerospace and photonics, because these days, aerospace and defense are marking the roadmap for photonics innovation. I'm standing outside Figma in Malaga. In just a few weeks, this building hosts the third Global Photonics Economic Forum. I want to tell you what is going into the agenda because the topics have never been more crucial to the successful scaling of our industry. Let me highlight just four. The first panel on day one, AI infrastructure. In late July, the chief executive of Lumentum, Michael Halston, said in public what many of you have been saying privately. The next shortage in AI infrastructure is not switch silicon, it is indium phosphide.
We see a huge shortage, and that's one of the reasons I think NVIDIA invested in Lumentum and invested in one of our largest competitors who also has incredible indium phosphide manufacturing capability.
Lumentum runs 5 indium phosphide fabs and is still shipping around 30% below what its customers are asking for. Michael gives a keynote on day one and joins the CEO panel. And on the AI infrastructure panel, Ash Kansayedi. At NVIDIA, he was part of the team that shipped their first co-packaged optic switch. He has just moved to AMS Osram to run their optical interconnect business. So the man who spent years defining what the buyer needed now sits on the side that has to supply it. Alongside him, Sienna, Seagate, Smart Photonics, Lyonics, TTM and Resolite. Greg Bartlett of Global Foundries will be the chair and moderate this crucial panel. Now follow the material back to where it comes from. China accounts for roughly 70% of the world's refined indium. Beijing put indium-related items under export control last year, which is why Day 2 of our summit carries 2 sessions on this, not one. A discussion on supply chain resilience will be moderated by Michael Levy, and our examination of geopolitics, supply chain and global representation will be driven by Marisa Edmund of Edmund Optics. We'll explore what resilience actually costs. On quantum, at the end of July, SealsQ began commercial deployment of thin-film lithium tantalate photonic chips from MiraX, a Swiss company and an Optica corporate member, for microwave to optical conversion. That is the quantum interconnect problem moving out of the lab and onto a price list. Chuck Matera moderates this session with PsiQuantum, Orca, Atom Computing, QSight, and Thor Labs. And we put the oldest question in our industry directly on the table. Can photonics reach semiconductor manufacturing economics? John Tisili of MKS moderates. Trumpf, Applied Material, Fix, Ficon Tech, and Lightweight Logic will answer. The 24th and 25th of September here at Figma in Malaga, the same week as ECOC and the same building as ECOC. The agenda is now live in the Optica website because we want your input on these very important global issues, and you will have access to the best minds in the business. See you in September, see you in Malaga.
A new season of the Optica Online Industry Meetings is launching soon. We're opening with Photonics in Ophthalmology and Vision Care. We'll catch up and discuss about the latest in optical coherence tomography, retinal imaging, adaptive optics, laser treatment systems, and high-speed data acquisition. These are not laboratory results. They're in clinics now, being used on patients today.
Let me say something about who is speaking. This is not a meeting where executives and engineers talk to each other about what clinicians might need one day. Most of the people on this online panel are practitioners. David Huang opens the meeting. He co-invented optical coherence tomography, and he will talk about where ophthalmic tomography goes next. Susana Marcos brings the visual optics side, how adaptive optics and wavefront sensing let us treat the eye as the optical system it is. Gonzalo Mullo from Optos speaks to deployment, what ultra-wide-field retinal imaging actually does inside a real clinical workflow. Nancy Aichawa, consultant ophthalmologist at Moorfields Eye Hospital, connects imaging to genetics and inherited retinal disease. And Larry Benjamin joins us from Orbis, the charity behind the Flying Eye Hospital, a full ophthalmic teaching hospital on board an aircraft. His question is the hard one. What does this technology need to be before it works in every setting, not only the well-equipped ones? We will also hear from companies building the components underneath all of this: Chilas, Indie, Fintech, Modulite, and Aquaris. So lots to discuss. Let's get started. Hello everyone, and I hope you all had a fantastic summer. And for those of you very lucky ones who are squeezing the last 6 days of August, I hope you are joining from a fantastic location. Today is a very important event. Today we are talking about ophthalmology. We have seen huge developments recently in the market, and we want to make sure that our corporate members connect with those driving the change. That's why we have a fantastic agenda full of practitioners. For those of you who is the first time at an online industry meeting of Optica, these are the rules of the game. This is not a webinar. You came here to listen to the presentations. Perhaps you're in the wrong room. This is a meeting to connect integrators with enablers. And today, as integrators, as I said in the opening video, we have practitioners from many different locations in the world, all the way from Oregon University, University of Rochester, Optos, Moorfields, and what you just saw, a fantastic development by Orbis. And our enablers today are everyone in the room, but those who actually ask to give a short presentation to the integrators are Chilas Lasers, Indie, Fintech, Modulite, and Aquaris. Today, we always work very hard for our corporate members. If you're in the meeting and you are not yet registered as an Optica corporate member, all you have to do is super simple. Optica.org/join corporate. Go there and register your company as a corporate member. This is the only way you have to make sure we continue doing our job for many more years. And today is ophthalmics. In 2 weeks and a half, we have applied imaging. This is a market revolutionized by AI. So you're developing camera systems or optics or electronics for cameras. You have to be there on the 15th of September. In a couple of more weeks afterwards, aerospace, then quantum safe network, then XR optics. Later on, new space on the 17th of November. We finish the season with quantum computing, and we open the new season with CPO, with co-package and pluggable optics. But as I said, today is all about ophthalmics. We love to join online, but we also love meeting people face to face. For those of you who are planning the calendar of Q4 2026, mark with a very, very strong pen, Malaga, 24-25 September, the Global Photonics Economic Forum, covering photonics as a business for every single vertical. Also, 21st and 22nd of October, we go all the way to Sunnyvale, and we have the Optica plus APC PEC Summit, Photonic-Enabled Cloud Computing. And at the end of the year, we go to very close to Paris, Saint-Germain-en-Laye. And there we're going to have our meeting hosted by Exile at the IX campus on aerospace and defense, with many of the most important primes in defense and aerospace in the world. As I said, today is about ophthalmics. We are live in YouTube, so look your best. And let me say hello to the YouTubers in the world. Hello, YouTubers in the world. If you have any comment or question during the meeting, please write in the chat and I will read it in the room. And this, of course, also valid for the people here with me in the Zoom room. We actually have
many of them today. If you have any question or comment, we're going to ask you to voice it, to ask yourself. What we want to do here is to connect the different companies providing nanoimplantation-based technology like Solnil all the way from Grenoble to connect them with potential companies who are using their optics. So let's start, and I would like to say, first of all, thank you very much. The great job that Dr. Helena Diaz, or Director of Life Science and Laser Technologies at Optica, has done, putting together this impressive agenda, this very impressive agenda of practitioners, researchers who are here looking for optics to make the dreams come true. And let me start very big today. We had the honor to have one of the co-inventors of OCT, a technology that has revolutionized many different market fields, including optics. Dr. Dave Huang, thank you very much for being with us today. The floor and the attention of our optics and photonics community at Optica is yours. I don't know if we can hear you.
Thank you, Jose,
Yes,
for that introduction. It's a pleasure to be here. And I want to thank Optica for organizing this very exciting program and allow me to open the session and talk about OCT and optical imaging in vision care. I do have some financial interest in some aspects of OCT technology. So lasers and optical imaging really have revolutionized vision care since about 1980. Advanced diagnostic imaging like digital photography, SLO, and OCT have replaced direct visualization and pen on paper drawing for the diagnosis, monitoring, and documentation, and taken a lot of guesswork out of making treatment decisions. Yes, we used to do a lot of guesswork decades ago. And laser systems have replaced some impossible or dangerous surgeries with very precise and predictable laser procedures. And of course, refractive surgery advances like LASIK is little short of miraculous. And I'm going to focus today on talking about diagnostic imaging technologies, including how OCT makes the invisible visible. So to start, simply replacing film with digital photography has been a great advance in being much more compatible with electronic health records, telemedicine, and AI. I show here an example, INUC, which I believe is a second FDA clear system for using AI and digital photography together for the automated diagnosis of referable diabetic eye disease. And thank you for allowing me to make a pitch for a company I co-founded, Go Check Kids, which developed and markets an iPhone flash photography app that detects and screens for amblyopia or lazy eye risk factors, such as refractive errors and strabismus or cross eyes. And in the past decades or so, we have actually screened more than 7 million children and refer almost 500,000 for proper eye care. Scanning laser ophthalmoscope, invented in the 1980s, allow us to produce wide field fundus imaging through an undilated pupil and improves contrast at the infrared wavelength, so we can use infrared light for high contrast imaging. And this has become important for serving the back of the eye for many eye diseases. And OCT started as almost a physics experiment for me as a PhD student to use light to measure the time of flight of light and seeing below the surface in Professor Fujimoto's lab at MIT. And of course, now it has developed into a three-dimensional micron resolution imaging technology that's used every day in eye care as the most commonly used imaging procedure in ophthalmology, and it's used to diagnose and monitor many eye diseases, including all the leading causes of blindness, such as age-related macular degeneration, diabetic retinopathy, and glaucoma. The development of OCT is itself a pretty amazing story. We first published it in 1991, the first patent in 1994, and the first FDA cleared system by Humphrey Zeiss in 1996, and the first CPT code, so you can bill for it, in 1997. And this led to wide clinical adoption, because you can now charge for it, and a virtuous cycle or rapid technological improvement, and all this in only 6 years. That goes to show the regulatory steps were a little bit easier back then, and I think the founders of this technology did everything right and were very lucky. OCT initially did have competition. CPT code 92135, scanning computerized ophthalmic imaging, included not only OCT, but also retinal thickness analyzer, a slit scan-based tomographic imaging, scanning laser, polarimetry, and tomography. And because OCT has higher depth resolution and has very versatile cross-sectional imaging that allow better diagnosis of eye diseases, eventually grab more of the market. And OCT was made possible by advances in photonics technology, such as semiconductor light sources and optical fibers, and many other components originally developed for optical communications in much larger industry. So we really were lucky in being able to take advantage of this much larger investment. This has been a very exciting field to work in the past 3 decades for me. There's a version of Moore's law for commercial OCT speed that speed doubles about every 2.7 years due to the evolution of the technology. And every time you have a leap in speed, it makes it possible to do new things. And these include many things, but I want to focus on ultra-wide field imaging and novel contrast, such as angiography and optoretinography. It's now possible to image almost the entire retina with an OCT scan. And one of the efforts in our research group is to develop ultra-wide field OCT for retinopathy or prematurity, a very important disease in premature babies. And these are examples showing that you can see to the very edge of the retina and see the edge of retinal development and complications that can occur there. This is Dr. Pete Campbell performing an examination of a neonate in the intensive care unit. And because this is infrared light that's invisible, actually doesn't bother the baby as much. And you can get a 3-dimensional, almost a whole retina image in about 20 seconds. OCT angiography is a new extension of OCT where we can map blood cell motion to map the vasculature down to a capillary level. You can get cross-sectional images, and more commonly we visualize it en face, and this is very important, for example, in visualizing the abnormal blood vessels in wet AMD. And it's already being used to look for loss of the normal blood vessels, circulation in diabetic retinopathy, and abnormal vessels in AMD. And we can see actually 4 different plexuses in the retina, which is only a few hundred microns in thickness, which is amazing. This also have a fairly rapid progression. First product launch in 2014. clearance in 2015 and its own CPT code just last year in 2025, so that it can be paid more than structural OCT. And optoretinography is yet another new contrast where we can see the function of the photoreceptors, the rods and cones, which lengthens by on a nanometer scale when it captures a photon. And we can detect that lengthening with visual stimulus and OCT scanning in the same place and actually map the response. And this is going to be useful in AMD and also inherited retinal diseases, in which a lot of advanced treatments such as gene therapy is ongoing, and a way to objectively capture a function is useful. So what does the future have in store for us? I think artificial intelligence, of course, is going to play a big role, just like our smartphone images now almost always go through AI processing. This is going to be ubiquitous in processing clinical imaging as well. It's now possible to put more and more components on integrated photonics on a chip. So this is going to eventually gradually improve both the cost, reduce the cost, and improve speed and other performance. Imaging-guided lasers and surgery is going to allow more precise treatment. I show an example here of injecting a gene therapy vector under the retina, a very delicate procedure. And with image guidance, you can do it more precisely, either with a surgeon or with a robot. And oculomics is going to be important, and that's using the eye as a window to brain and heart diseases. This is showing capturing of hemodynamics using Doppler OCT of the retinal artery. I think it'll be important in detecting valvular heart disease. And in neurology, we can see manifestations in the retina in different patterns. And this might be helpful in multiple sclerosis, Alzheimer's disease, and other neurodegenerative diseases. In all these cases, these advances are possible because engineers and clinicians are working together. And that will be the case in the future as well. So I'd like to acknowledge support for my research by NEI and other grant institutions. And this is our research group, Center for Ophthalmic Optics and Lasers. Please check out our website, coolab.net. Thank you very much.
Thank you very much, David. This is actually very good. I mean, it's a lot of things happening right now. So one of the things is like moving from OCT to OCTA, ultra wide field, optic retinography. Which is the technical parameter that is now the main limiter for getting in success with this? Is it the sweep speed, the sensibility, the motion correction? What is the parameter that is more limiting, or the parameters that are more limiting for it?
I think speed is the main parameter that is that's limiting and that's changeable. Of course, resolution also matters, but with the improvement in speed, we'll be able to do more. And that's mainly limited by how much light we can use on the retina, safety consideration. So there's a technological improvement balanced by consideration for light level safety. And I think acceleration by AI will be possible. And there's actually a lot we can do there. It's going to slow it down, maybe FDA clearance. But I think that's going to be the future.
Yeah, absolutely. The other thing is like OCT moved from structural imaging to functional imaging. So, what is going to be the next clinically trustworthy enough for adoption? Like, is it going to be new biomarkers, or is it going to be relying on the technology itself?
I think, for example, in angiography,
Mm-hmm.
Mainly, we're just using it to visualize circulations. There's a lot of quantitative biomarkers that we are able to measure now that are just starting to be adapted into clinical practice. So I think there's going to be room for a lot of advances in the management of diseases as these biomarkers become validated and become FDA cleared and become available. And again, AI is going to make a lot of these measurements more reliable.
Okay, perfect. So we have Jerk here in the room, and he's making a question. So Jerk Rose from Ipsen Photonics, they make these beautiful mini spectrometers. So Jake, can you please unmute yourself and ask your question?
Yes. So thank you for hosting this, first of all, and thank you for a very interesting talk. I think it's really intriguing that the eye is one of the, if not the only place where you can actually see living tissue. But what is required technologically to actually see something to diagnose the brain and the heart? Does everything exist, or is it image processing that needs to be done, application development?
I think the circulatory system is what connects the eye to the heart, and we're going to be able to assess a lot of hemodynamic and arterial and venous and microvascular disease conditions by looking at the eye in great detail, the retinal circulation in particular. And that requires accurate ways to measure blood flow and the vascular in the eye. And the basis is going to be a fast OCT system and advanced software for making those measurements. And all of these require making multiple measurements at the same place to image motion. So ways to control for motion is going to be important. And for the brain, it connects to the retina through a cascade of neural pathways. And the retina is really, in some ways, a part of the brain. So by looking at its structure and circulation, amazingly, we can see often early manifestations for many neurological diseases.
Yeah.
Okay, thank you very much.
Yeah, so we also have Mark Kaminside. So Mark Kaminside for Kaminside Solutions. So Mark, can you please unmute yourself and tell us your question?
Yeah, basically, just as he was saying that you could look at things like endothelial dysfunction, perhaps even early catching sepsis if you had things that were very portable. And then would you ever be able to do these sort of tests even at home using an iPhone or something similar?
Catching sepsis in the hospital, perhaps in the ICU with a portable system. I think that's technically very feasible. I think the main impediments there actually have been probably regulatory approval and clinical adoption. Ophthalmologists are very familiar with imaging technologies like OCT and SLO, whereas intensive care doctors are not really trained on it, and this is a kind of an alien technology. So having sufficiently broad applications, being able to use it on several diseases so the doctors there are familiar with it is probably going to be the door you need to open before this is used there more. But technically, I think it's very feasible. Same with home. I think the barrier is more economics. It's going to cost a lot to use it at home. And I think this area will gradually develop as the cost of these systems go down. We really have to put the whole OCT system on a chip, I think, for this to become really economically easy to implement. Of course, we're already starting to have home OCT systems. So there are experts there who can probably speak to this better than I can.
Perfect. So we also have in the room Travis Scott from FinTech. So Travis, could you please tell us the question?
Hello, David. Thank you very much for the talk. Yeah, I just wanted to ask a question about BCI and where you see the future of human brain-computer interface in the near future. Because I think that this is kind of like piggybacking on the question from, Bjork. Is that how you pronounce the name? So it's just like, yeah, the next step after this retinal level, how do you get to BCI after that? And what your opinion is maybe on the whole BCI topic as a whole?
Well, I don't know much about BCI except that they already use OCT to guide the implantation of electrodes in some instances. And I think OCT angiography might be useful as well. So you can see the blood vessels and avoid them. And so I think this is one area where imaging guided surgery make a lot of things possible. And OCT being able to see below the surface is going to be useful in the future, and I find it very exciting. And of course, this I am sure this is a science fiction-ish, but a real application that's going to develop in the future. It's just a matter of how fast.
Okay. So we have two people in the room because we were talking about laser guide surgery, but also we talk about the speed of the data. So I would like to call first Ian van der Becker from Childless Laser. So they make tunable laser technologies in the light engine behind the next generation sweep source for the OCT. So Ian, can you please let us know like how you can help David and in general for the new technology developing here?
Yeah, should I just open the presentation as well to go with it?
Yes. This is the moment.
Easy. Yeah, this should be it. So hi, I'm Ian van der Flecket, business developer at Chilas Lasers. And let me first preface this that I'm not an ophthalmology or vision care specialist, but here at Chilas we do know something about lasers. So first off, at Chilas we make hybrid integrated external cavity lasers characterized by broad tuning range, ultra narrow line width, and excellent repeatability, which makes it a great source for example, swept source systems. We have demonstrated before at longer wavelengths, such as 1550 and 1600, but are also now bringing prototypes on the market for 980 nanometers, 1064 nanometers, and what we already had is 850 nanometers. And what I wanted to focus on today is show some of these exciting colors that we have developed here and see how this could be integrated in applications fit for example, ophthalmology. So our PIC-based laser fit into many applications due to multiple factors, such as flexibility of operation of the laser. We are a very flexible company and can adapt the laser to whatever the application is. Its size due to being a PIC-based laser, so it's excellent for scalability and integration and compatibility with many different wavelengths. So not only 980, 1064 is possible, but you can also see to adapt it to a different platform altogether. So I think for the presentation that Dr. Wang also gave is that 1064, 98 and 850 would especially fit there. And in that light, I would like to explore with him and with the other participants in this meeting as well, how we can make the perfect Atlas laser for your application and how we can see how to fit this into your initiatives. Yeah.
So thank you so much, Ian. So I hope this is something that that is going to be. I like as I said, what is the ideal light source for OCT, and this is one of the open questions all the time. But I want also to call Laurelyn David from Aquaris. So they do the high-speed data acquisition and captures that signal fast enough to use it. A lot of experience in different markets. So Laurelyn, the floor and attention is yours. Ian, could you please stop sharing your slide? Yeah, thank you. So Laurelyn, all yours.
Let me share. Could you see my screen?
In 3, 2, 1, yes.
So, hello everybody, and thank you for inviting me today, Elena and Jose. My name is Lauren David. So, quickly, I want to present you accurate signal acquisition solution for swept source optical coherence tomography. So, our technology enables high quality SSOCT 2D and 3D real-time imaging. So, we offer a complete solution with hardware, including a high-speed data acquisition card, also named DAC card or digitizers, with the whole OCT signal processing in real time on board, and an OCT dedicated development environment. This complete engine allows excellent performance and low latency. So low latency is key, of course, for ophthalmology. Of course, it's also crucial to guarantee high image quality, especially for early disease detection, and we also mention application requiring surgical guidance. Our approach is based on the digital case-space resampling of the OCT signal, also named dual channel mode. Our approach minimizes artifact and noise, enhancing the image resolution and clarity. In addition, our solutions are optimized for OEMs, so to make the integration easy, they are very flexible. Technically, we are laser source independent. We can also integrate we can support the galvo driving directly from the DAC card. We can support 2 synchronous OCT channels for polarization sensitive OCT or multimodal application. Our solutions are ultra compact, cost effective, and open for customization. This diagram illustrates our portfolio for SSOCT and ophthalmic application. So quickly, horizontally, you have the scan rate, and vertically, the maximum imaging depth. With our 3 platforms, with the essential platform in red, mid-range in green, and the high performance in blue, going from the slower to the higher speed, we typically cover the needs for ophthalmic imaging. So for retina imaging, a few millimeters up to the whole eye biometry, or we also, or as has been mentioned before, for ultra wide field. And in terms of scan rate, we can go from 50 kHz scan rate up to 1 MHz or above. To conclude, to our users benefit from a complete portfolio, low development risk, accelerating their time to market. They can rely on stable product with long product life cycle as typically expected for medical applications. If you have any questions, please go ahead or feel free to contact us.
Thank you very much, Laureline. Definitely there will be a lot of questions and a lot of contacts. But allow me to go back to David. David, it is so great to have you here. And there is a question that is the million-dollar question. You know, there's lots of different light sources that are being used in OCT today, from superluminescent diodes all the way to ultra-fast lasers, broadband lasers. We are seeing pixels. We are seeing, well, anything. If you could have a magic box in which you could get out the ideal laser for OCT, which one would it be? What is the ideal laser for OCT or the ideal light source for OCT?
Well, there are many considerations, but I find it really exciting to see all these hundreds of kilohertz or megahertz light sources. I think that might be a sweet spot for eye imaging, retinal imaging, and I think this is going to be the swept source OCT with these light sources, high-speed light sources, definitely going to be dominant in the near future, and it's very exciting to see them. You've talked about all these parameters that make it practical. I mean, they have to be reliable, low noise, have adequate depth range, and produce phase stable swept source. You can time it or synchronize it easily, and so that A to D is relatively simple. And cost is going to be very important because we want to improve the performance, but there's not a lot of headroom on how much more you can charge for the clinical customer.
If you have an affordable narrow line with kilohertz, swept source, mode-free, tunable laser that actually even fits on a chip, then they are making David very happy. If not, in the meantime, there are many different contributions. David, it was so great to have you here. Stay with us because the conversation continues. We're going to go now to the University of Rochester, and we're going there to welcome one of the key figures in Optica as an end user and as a researcher of optics for ophthalmics. She's going to talk today about different presbiotic corrections patient to patient, customization of presbiotic corrections. Susana, muchas gracias. Thank you very much for being with us today. The floor and the attention of everyone goes to Dr. Marcos.
Thank you very much, Jose and Elena. Can you hear me well?
Loud and clear, as you were here next to me. But could you go full screen on your presentation or presentation mode?
Yeah.
Yeah. Let me. Here we go.
Fantastic.
Here we go. Yeah. Yeah. Well, thank you so much for having me today. I'm actually calling from Spain from another conference, the International Society for Eye Research. But yeah, it's a pleasure to actually skip one of the sessions and be with you today. And I think it's great that Optica is dedicating a session on ophthalmic technologies. I think for various reasons, I mean, the eye is and ophthalmology is very tech oriented. There is both optical technologies for diagnostics, but also for corrections. So it's all about optics in the eye in many ways. And also the eye itself is a fascinating optical instrument. So there's so many reasons to have Optica around the eye and around ophthalmology. And today we'll be talking about, experience that we have from going to diagnostics technologies we develop in the lab to investigate fundamental actually aspects of the spatial limits to vision, and the adaptive optics, the technology that is inherited from astronomy, all the way to clinic for imaging, but actually to visually simulate prospective corrections, prospective intraocular lenses in particularly in patients. And the motivation is here, right? It's like when you go and are thinking of buying a car, you want to drive it first, right? Also, when you are buying shoes, you'd like to talk with them, right? However, when you are given an intraocular lens, there is actually no way to test how you're going to be seeing with these intraocular lenses, right? So when you, similar to a car or shoes, test drive your intraocular lenses prior to surgery, right? It's something that you're going to be having the rest of your life. And the thing is more complicated because there's over 180 intraocular lenses in the market. There is optical, concepts behind them, but there can be monofocal lenses, they can be multifocal, they can be diffractive, they can be depth focus. You put different lenses in each eye. So it's very, very difficult. It's very difficult to actually convey a patient how they're going to be seeing with those lenses. And in fact, probably the difficulty of managing these expectations is the reason why, despite all the efforts from optical engineers and all of these companies to come up with these new designs that can actually help many people in having functional vision at far and near after cataract surgery, there's only 12% of the lenses that are implanted in the world that have these premium surgeries. I mean, it's the most performed surgery in the world of any specialty. There is 30 million cataract surgeries per year. So you can count how many intraocular lenses are implanted every year. So huge market and a big need to really, manage expectations and actually link patients to their optimal correction. So this is a need in ophthalmology. It's hard to manage spectroception lens, and the technique that we actually brought from the lab into the clinic to really resolve this need is what we call the Synvis Gecko. So this is a binocular simulator of multifocal lenses, or in general lenses for presbyopia correction. It looks like a virtual reality system, but it's not. I mean, it's real optics. It's the optics of the lenses is programmed, it's see-through. You can see the real world. It's binocular. It's hand-mounted. It has a large field of view, and it's fully wireless, so that the clinician actually just have to select the lenses that they want to try in each eye, and the patient can see through those lenses. And as I said, this actually came from, work in the lab through these adaptive optics visual simulators and, big engineering talent to bring these optical tables into a small footprint system. But, this is a portable commercial clinical device, and it actually has programmed many of the lenses in the market. It is interesting that, you have the hardware. The key optical technology inside is optotunable lenses that we use to recreate the specific optical design of each lens through the concepts of temporal multiplexing. But the hardware is there, the lenses are programmed, they're selected in an iPad. So the updates of new lenses coming is done in software, but the platform is the same. It can also simulate contact lenses, so it's a really wide, broad platform. So we start from the intraocular lens profile of the lenses. And, this is converted into a temporal multiplexing profile and uploaded in the system. Nice thing is that you can really simulate and reproduce post-optic vision with different market intraocular lenses. So I'm showing here in red is the simulated lens. So these are through focus visual acuity. So it's basically visual function in patients as they're looking at far and near. So these curves represent the more visual acuity at different distances. So in red is with the simulator, in black is with the actual implanted intraocular lenses. So we're actually bringing the experience of the post-op vision pre-operatively. And the nice thing is that now a patient can actually experience different intraocular lenses, right? This is something that, when you're implanted one lens, this is what you get, right? Now, prior to surgery, you can compare your through focus vision with the different lenses, and sure enough, different optical profiles actually result in different visual patterns. And now you can compare and select the one that best fits the patient's needs and vision. So this, the market is cataract patients. Of course, there's cataract surgery is no longer necessarily a surgery to eliminate the scattering produced by the opacified lens. It's also a refractive procedure, and it's also like a presbyopic procedure. There's more and more people, getting these lenses even before the lens becomes opacified. It's called clear lens extraction. But of course, can you use this system through cataract? Well, this is a study published in the Journal of Cataract and Refractive Surgery, where the visual perception was measured through the different lenses at far and at near through the device and the cataract. And then the same patients got monofocal intraocular lenses implanted. They found that there is a good correlation between the pre-op scores through the simulator and the post-op scores. There is an improvement in visual quality, of course, but then the selection of the lens, the lens that produces the best quality, but at far and near, that was selected through the cataract, and the simulator happened to be the same one that they would have chosen through a transparent lens. So it can be used in through cataract. Of course, different optical design results in different halos in the patient, and you can see that through the simulation. You can also see these differences in the halos between diffractive lenses, EDOF lenses. So a good representation of vision with those lenses that will, give the patient and the surgeon good perceptual cues to actually select one lens over the others. So this is implemented in the clinical practice. The system is aligned. The patient can experience different intraocular lenses. You can also use the system to measure ocular dominance. So patient education and expectation management use, but also the possibility to measure visual function and visual perception through all these different lenses. So this is an example of a technique that, was born in the lab and is now used across many different clinics in over 20 countries. And it's being used in the clinical flow to really, help in the selection of these intraocular lenses. And it's actually helping to increase patient satisfaction and also to really fine-tune the best option for the patients. So we are seeing, that this is data that are being collected from the clinics where it's being used. There's 55% of the patients that actually shift from the initial planning from the surgeon. 11% opted for monovision, 16% opted for monofocal intraocular lenses, but 82% opted for a premium intraocular lens, meaning that, this is really increasing, and the fact that, expectations can be managed, it's increasing the penetration of intraocular lenses in premium intraocular lenses in the clinic where it's being used. Where this technology can go further, we have now current prototypes at the University of Rochester that combine these see-through systems, now not by temporal multiplexing, but using spatial line modulators and spatial representation of those lenses with dynamic aberrometry, where we can actually expand these into patients that now have the ability to accommodate. That includes myopia control, so a different population, completely different population, but children that are undergoing myopia control with multifocal intraocular lenses, contact lens fittings in early presbyopes that still have some ability to accommodate. So really, the possibility to expand through some new features, the target population, but with the same idea. It's really providing the patient's experience of vision through novel optical designs, and also tracking how they're actually functioning with these lenses and how accommodation is coupling with the new designs. It's interesting because in general that really couples with this idea of having new technologies for improved contact lens and intraocular lens design. Imagine you can do that before the lenses are manufactured. So it's really helping in identifying new designs, also selecting those in the clinic and evaluations. And that's kind of part of the big pipeline that we envision how those new corrections should be selected. First, and that links with David's talk, we believe that the use of three-dimensional quantitative optical coherence tomography, interior segment, and of course axial length, and optical coherence elastography allows us to construct digital twins, like custom model eyes, where we can truly select on anatomical basis and optical basis the best lens for an individual. We also have, as part of our adaptive optics visual simulators, span out another technology, which is the Quick See by Planoptica, that also produces very accurate refraction based on Harman shockwave and sensing. So we can have a very accurate description of the best lens that gets implanted in the eye, that produces the best retinal image quality, the best optics. But then, of course, vision is much more than optics. It incorporates visual perception, and this is where the selection of these lenses can be further fine-tuned to the perception and visual function by the use of these visual simulators. So this is where we think the customization of the corrections should go in the future. And I think I leave it here. Thank you so much for your attention.
Thank you so much, Susanna. Actually, I mean, it's really nice to see this. I mean, we know you have been working in personalization for a long time now, and now a question that it just came to me is like, how to make this. What is needed in the technology to make this be part of the workflow for all the treatment?
That's a good question. So right now, the visual simulator is being incorporated as part of the flow, right? So it's kind of a final tech on what the lenses should be in the final stage, where the doctor is is having this conversation on which lens to actually select. But as you say, that could be, and I think this is represented in this cartoon here. It can be part of a platform, right? So a platform that goes towards customization. Some companies are already talking about, like this OCT-based, corneal refractive surgery and selection, where you have like ray tracing through the surfaces of the ocular components. You could have this as part of your refractive surgery or your cataract refractory surgery suite, right? Where you would have the like the diagnostics OCT based like data to construct these custom model eyes, and then you can have the similarly to a phoropter, right? That you have for like testing the corrections for like standard corrections in spectacles. You could have these visual simulators that really give the having or perspective vision through those lenses. So yeah, I think you're right. And the way we envision it is actually like a pipeline for really improving the selection of lenses. Mm-hmm.
Okay, so Optica question is what you can do for us. We got it very clear. What else can do for you?
Mm-hmm.
Give me your major challenge.
So we are, and we're improving these simulators by the use of spatial light modulators, for example, where the lenses can be represented in not temporally but spatially. So those tend to be those technologies, including also like adaptive optics, deformable mirrors. They tend to be mirrors, right? They tend to be reflective technology. So having adaptive optics technologies like SLM and deformable mirrors that are see-through, that are lenses and not mirrors, will make those systems even more portable. The idea is we're simulating these lenses on those devices, and those are being projected in the eye. If we have something that is completely see-through, the footprint of the instruments can be even smaller.
Okay, perfect. So yeah, so it's just, I mean, it's really a lot of things, and there are so many of our corporate members, not only that can help in the technology with the parts, but also people that is working in things that they are not exactly the same, but they are similar. So you are going to need like a lot of chips in there, but it's going to be the light source. The adaptive optics, as you say, is one of the most important things here. David is making a comment. So David, can you please open your mic and say yourself, because this is the question. This is a very good question.
Oh, Susanna, I was really curious about your simulator results in IOL. You kind of lump multifocal and EDOF, extended depth of focus, together. They're very similar concepts for sure, but I think they produce pretty different trade-off between range of focus and photic effect. So I'm curious, between those two, after going through the simulator, what do patients generally prefer?
That's
More
a good
often?
question, and
Yeah.
that is a very good question, and this is one of the reasons why simulating and really being able to see how you see through those very different concepts, right? The multifocals tend to be diffractive lenses, and the EDOF lenses tend to have a smaller depth of focus. And what I would say is that it really depends on the patient. You show them what's the benefit at near, right? And of course, the multifocal lens tend to be to give a higher benefit at near, and you see that also in the through focus curves. But you also show the degradation at far, right? And there are some people that are more tolerant to the reduction in contrast at far, and there are other people that they would go to an EDOF lens because they preserve better their far vision. So this is very subject dependent. Also, something that is very interesting is that, of course, you can test like different corrections in each eye. So one thing is the fine tuning can actually go into some mini monovision, right? Or one of these modified monovision where you can have even a monofocal correction or an EDOF correction in the dominant eye, and then a multifocal correction in the near eye. So there's all these tests that can be done, like mix and match, that I think manufacturers and doctors were hesitant, right? Because you don't know how their patients are going to be liking those combinations, but now you can go and test them and see the patients the reactions to those and have a more informed decision.
So people have clear preferences. They're not just like, oh, they're kind of, I can see both are good. That they actually have clear preferences because they're different personality. It's kind of amazing. People with split.
So it's not only their personality, it's also how this is being combined with their own optics, right? Was their pupil diameter, and also their prior adaptation. So there's people that have higher amounts of aberrations, and they are adapted to more of a decrease in contrast or in vision. Then so it's personality can be. There's people more picky, but then it's not you explaining or you're going to lose a little bit of vision. It's like they can attest for themselves. Yeah.
Okay.
Yeah, excellent. Yeah, and that's one of the things. This is part of being of the personalization. This is what we are moving forward and forward and forward in general in all medical. So it is and in our life, in general life. So this is great. So we have Lander Sickle from Venture Capital. Lander, you have a question for Susana. Could you please unmute yourself and tell your questions?
Yeah, Helena, thank you. And hello to Susanna. Thank you for the presentation. It kind of takes me back to the early days of personalized laser vision correction. You have the shout out to the Hartmann-Jack aberrometry. Now, my question is, with your eye simulator, you're able to move patients into advanced IOL designs because you are able to simulate for them their visual outcome. But what are your thoughts on closing the loop to actually include post-op visual performance and satisfaction? And that brings me to the question from your point of view, what are the remaining top 3 to 5 variables in today's cataract surgery that are the remaining sticky impediments to perfect vision post IOL surgery?
Yeah, very good question, and I think having this pipeline here, if I'm still sharing, that is very valuable. So the main source of error in cataract surgery is the IOL power selection, and one of them is the ELP, predicting where the intraocular lens is going to fall. Quantitative, including information on the crystalline lens, like the full shape and volume of the crystalline lens, we're actually being much more accurate in determining the position of the intraocular lens. And you can see here, I only brought like an image of the crystalline lens that we can now, using like prior knowledge database, machine learning, and other technologies, we can really very accurately predict outside the margins of the pupil. So by using all these three-dimensional information of the crystalline lens, we are getting very precise in determining this position of the lens. Another question is like the current formulas for IO power calculation. They are very basic. I mean, they're based on regressions on populations, and they just use corneal curvature and action length. But you can think on having these digital twins and do a ray tracing and actually not being limited by some of the current limitations of these formulas that fail in post-refractive surgery, from post-corneal refractive surgery patients. So you can ignore like these IO power calculations, traditional ones, and do a real selection of identifying the lens that produces the best optics in the back of the eye. So that will be like an advance now possible through like technologies like OCT. And then the third is there is optics, and retinal image quality doesn't equal visual perception, and this is where like these visual simulations come in.
Yeah, thank you so much. So talking a little bit about more about the personalization. So we have Indie, and Indie get the slits and broadband light sources, personalized corrections, depends on high resolution ocular biometry and OCT guided planning, which runs on the same broadband source technologies. And someone that can talk about that is Marcus Duell. So Marcus Duell from Indie, the floor presentation is all yours.
Thank you very much. And you
Susanna,
need
can
to
you
let
stop
me.
sharing, please? Yeah. We need.
I'm still sharing.
Yeah, you're still sharing. Sorry. Yeah. Thank you.
Sorry about that. Okay.
No, it's okay. No worries.
Okay.
Okay, Marcus, please go ahead.
Yeah.
And this is going also to connect a little bit not only with Susanna but also with Dave on the sources before.
Okay, yeah, thank you very much for having me here. I will talk about broadband light sources for OCT or SLO or other eye imaging technologies, mainly focusing on superluminescent diodes, SLEDs. So probably some of you know us already. We have been providing broadband light sources or broadband SLED sources for OCT or SLO for more than 20 years. We cover a very wide wavelength range from the near UV at 390 nanometer to the near infrared at 79 nanometer, with different bandwidth values ranging from 10 to 200 nanometer. We have been part of the Indie family since 2023. So basically, before that we have been Exelos, but now we are part of Indie. And basically, what you see in the lower right-hand corner is an example of a very popular SLED that is used for spectral domain OCT, which I think is still, if we look at OCT systems in the market, that is still the number one dominant imaging technology in OCT, even though there have been a lot of discussions about swept source OCT due to the higher speed. But as of today, I think the vast majority of systems that are being actually commercialized even today are based on spectral domain OCT. And what you see here, that's a typical example of an 50 nanometer broadband light source at 840 with maybe typical X-fiber output powers in the range of 5 to 30 milliwatt. As David already said, that is also partially limited by the laser class 1 safety limit that needs to be obeyed for these medical systems. And another example is basically if you want to go to higher resolution, and David already mentioned that there are trends in ultra high resolution imaging, the optoretinography, So we have been also developing combined SLED sources where actually in the same optical module form factor, like a 14-pin butterfly, you have 2 or 3 or 4, or sometimes even up to 5 SLED sources that are spectrally combined in order to broaden, to have more bandwidth. It's a patented approach and we have been commercializing these sources, as I said, for high resolution OCT or OCM imaging system. And there are just some examples shown below. If you combine, for example, 4 sources, you can have an ultra wide 3 dB bandwidth of 160 nanometer, around 840. And that gives you an actual resolution of around 1 to 2 micron. And that's very interesting because then you can basically see individual cells. So that's basically the type of products we have been offering to OCT for the last 20 plus years. Thank you very much.
Thank you so much, Marcus. And now it's the time that we start moving into the clinical department and the workflow. And our next speaker is Alan Anderson, the VP of Advanced Research and AI at Optos. Alan will bring the industry deployment perspective, advanced retinal imaging, AI, and clinical workflow integration. Alan, the floor and the attention is all for you.
Excellent. You see the slide okay there?
That's perfect, and I can hear you well.
Excellent. So thank you for giving me the opportunity to introduce Optos and I guess where we see I guess the clinical workflow evolving from the perspective of retinal imaging. So Optos were founded 1992 out of a rather, I guess, personal backstory for Douglas Anderson, our founder, and no relation. So his son in 1991, just while OCT was being born, Leif suffered detached retina in one of his eyes and lost sight in his eye. And it really was that sort of personal beginning that drove our founder to start the company that went on from sort of strength to strength, being acquired by Nikon just over 10 years ago. So this was the quote that really triggered a father's frustration around not being able to really manage the health of what was Leif's one good eye. And this was what prompted him to go away and come up with this ultra wide field technology, which is essentially based on an ellipsoidal mirror and gives this unique ability to see inside the eye for rather extreme fields of view. So state of the art at the time was the sort of indirect ophthalmoscope, which might have offered 30 degrees field of view. And then with the introduction of this ultra-wide field technology, expanded up to 200, which is very much the majority of the retina. And in terms of practical impact, there is a very visual one here. And we see this is what a detached retina looks like, the layers of the retina peeling off. And this starts typically out in the periphery and moves towards the areas of central vision. So early detection allows opportunities around treatment and intervention and can indeed be sight-saving. And then since we've kind of put this technology out there, it's now being used to detect and manage over 300 different diseases and different disorders and how they present in the eye. So it's been quite a profound step forward, I think it's fair to say, in retinal imaging. And it's based on I guess, scanning laser ophthalmoscope. The principle of it is really just scanning lasers in a kind of raster scan fashion across the eye. And we use lasers because they give a very good penetration through not only cataracts so that you can visualize the retina, but also it gives some good penetration down into the choroid. So you don't quite get a 3D visualization, but you do get information returning back from the different layers of the retina. And we achieve this with the ultra-wide field ellipsoidal mirror, which allows the focal point to be positioned around the pupil, and that gives us this magnificent access without having to contact the cornea, which is another method for achieving the ultra-wide field. And then latterly, we introduced into the same platform optical coherence tomography, because it does genuinely give you that 3D structural information. So we feel it's a nice complement. So in terms of what the Optimap offers, we offer the sort of the standard kind of color view, but then subsequently the angiography visualization was added. This is indocyanine green angiography and fluorescein angiography on the right-hand side, and then the natural autofluorescence of the retina when excited with green or blue lasers. And then latterly, we introduced Silverstone, which is that ability to just literally take an OCT of anywhere within that 200 degrees field of view. So in terms of retinal imaging, a term that's mentioned very often is multimodal. And this is because every modality gives different insights into the goings on within the retina, and typically are very complementary. So when we now consider so I guess imaging's role in eye care, it kind of is covered in these kind of clinical steps in terms of detection, diagnostics, prognostics, and treatment. And multimodal imaging, I think, is undoubtedly been really a big breakthrough in terms of allowing us to detect earlier, to make more insightful diagnosis and I guess hint towards prognostics. But I think there's a whole presentation separately here in this in terms of the opportunities that AI bring in this area will really supercharge this. But perhaps maybe an interesting perspective for today is to look at this through the sort of the treatment perspective. Indeed, diagnosing and detecting diseases is one thing, but the real breakthrough comes in the treatment. The more you can treat, the more interventions you can make that saves vision loss and sight. So very much for Optos, these are, I guess, they have driven current imaging needs, and we expect to influence the imaging needs going forward. So I'm just going to go through a sample of some of these, some new and emerging, and some very much established. So just kind of looking through this area of interventions where technology has been brought to bear to help with eye care. Some of them have I guess been touched upon already. So right at the beginning, I guess there's the sort of what probably with glasses is still an emerging area of technology with light in terms of the photobiomodulation. So using light therapy to address to diseases like age-related macular degeneration, or to slow down myopia progression, I think are some very probably early days with the science. There's been some promising clinical outcomes, but it is certainly one that certainly from a retinal imaging perspective, we would see our contribution there about monitoring effectiveness at this point. Other areas that are emerging, but I think maybe potentially further on with the science, is myopia progression. We all probably appreciate that myopia is probably emerging as a future epidemic, and we're lucky enough that the treatment options are beginning to appear, whether that's contact lenses or glasses. We're introducing a peripheral blur can really change the growth trajectory of developing eyes. And the reason to do this is shown kind of down to the lower left in terms of if myopia progresses to pathological myopia, not only does it increase the chances of retinal detachment, which was obviously close to the Optos mission in terms of trying to prevent avoidable detachments, but you can also see that the elongation and maybe also sort of the forming of a staphyloma there in terms of the degradation can have vision-threatening consequences that if we can treat upstream, it can really be impactful. Now, this is a laser surgery for refractive correction. It's a fairly well-established front of the eye procedure. Maybe not fully recognized is that within the clinical workflow for that, retinal exam will be performed specifically to look for any risks that might be presented that could lead to side effects from the laser treatment. And this is an example here where out in the far periphery, you see a horseshoe tear, and we can take our device and not only have that image reviewed as an Optomap, but we're able to do a cross-cutting of that with the OCT. So this would be something that would be recommended to be fixed before proceeding with the laser refractive surgery. And injections probably are the most used surgical intervention, I believe, in eye care. We started with the modalities, fluorescein angiography or indocyanine green angiography, where there's injection of the dye into the bloodstream. You can look through the sort of gateway into looking at the vascular system through the pupil, and you can see this image and assess the vascular or the perfusion of the ability to get oxygen across the retina. So things that you don't want to see are leakage areas or areas of new vessel growth. And this would be treated by another injection, anti-VEGF, that should suppress that new vessel growth. Or indeed, there's the more traditional method of applying laser retinopexy in order to scar the tissue and stop any bleeding that can occur. And a final one, just again, the theme of detached retinas runs strong. Here we see a detached retina where it's peeled off and actually is impacted the fundus, the central vision area. And part of that treatment is to introduce, in this case, silicone oil to press the retina back into position for treatment. So very much a whistle-stop tour of areas that drive or areas of eye care treatments that drive imaging use cases. Just before I finish, just a quick nod to, I guess, in terms of that was very much the clinical facing side of Optos. It does take an awful lot to bring a successful product to market and sustain it. It's sometimes the photonics and optics performance drives the headline performance and the exciting parts, but it's a comprehensive set of skills and expertise is needed to aggregate that into a successful product. So that was my 8 minutes worth. I hope I managed to stay on time there, but I'm certainly happy to take any questions now or.
Thank you so much, Alan. So yeah, I'm a little bit. The timing is a little bit my fault. So so thank you so much. This is quite interesting. So one of the things is like, how do you see the multimodal imaging evolving? So is it going to be for wider fields, for deeper information, for functional signals, better fusion existing in between existing layers? So, what is the perception of Optos on this?
I think undoubtedly we expect. I think maybe in all aspects will move forward. We serve quite a diverse market in the sense of high street optometrists and opticians, where there's a lot more, I guess, screening emphasis all the way up to vet surgeons and retina specialists. So there's, I think, probably wider, faster, deeper imaging, certainly in the OCT sides. I think cost is another aspect around if we can take the cost down through miniaturization or indeed I guess the economies of scale. I think that there's definitely opportunities there as we look to, I guess, get the technology out maybe beyond the hospital or clinic setting out into more primary care settings, because a lot of these things, particularly with AI, will be that aspect of the earlier you can detect, the earlier the intervention is possible. So again, going to that theme of trying to save vision loss, much of it starts with early detection.
Yeah. So, of course, I mean, I have to ask you, what is your major challenge here? I mean, how the photonics industry can help you to succeed, to continue, to scale, and to move forward in the next technology?
I think I guess is just that it's keep pushing those boundaries. I think that when you think of the technology advances that are very present in the ophthalmology space, it's still very much going through that growth phase where the economies of it mean that new enhancements can be brought to market if they can offer that ability to differentiate in the market space. So we continuously are evolving and developing our products just to keep pace with their competitors. And then on top of that, we're always very interested in looking at novel technologies that can give us something unique to expand our multimodal offering. So that's I guess in terms of it's kind of wider in terms of more modalities and deeper in terms of just pushing the performance limits of the existing architectures.
Yeah. So we have actually Joshua Green from Weber Electronics. Weber Electronics is a company based in Montana that makes the drivers for the lasers and other things. So Joshua, can you please unmute yourself and ask yourself a question?
Absolutely. Thanks, Elena. Appreciate it.
Sure.
Hi, Alan. Great presentation. Really fascinating to see behind the working scenes. You don't get to see that all the time. My question to you is, what, if any, electronics challenges are getting in the way for your researchers, engineers that are developing new systems, new products, any of the stuff getting in the way of going to market? We're seeing a lot of miniaturization across all the industries that we're in right now. So yeah, I'm just curious to know, what electronics hurdles are you guys tackling, if you're aware of any?
Probably, I think in many ways we're maybe followers with electronics in terms of we tried to take advantage of the traditional Moore's law in terms of obviously it's brought a lot of processing capability for a watt of power. We can do an awful lot more now than we once could. So I suppose we're quite blessed in that side. So I probably wouldn't say that electronics challenges. I think maybe it maybe goes back to supply chain challenges that are being part of a global marketplace, and the speed at which electronics moves is maybe a challenge to reconcile with the sort of medical device industry, which is a little bit a different cadence to the commercial one. So I think maybe that would be where longevity of supply, probably a key one.
That's relatable.
Yeah.
Yeah. Okay.
Yeah.
Good to
Yeah.
know.
It totally makes sense. So yeah, I would like to, because this is one of the things. I mean, everything is towards miniaturization, and especially in medical, not necessarily everything, but especially in medical. And one of the things that we need is better chips, better co-packaging, better precision assembly. So someone that actually can talk about that is Travis Scott. So Travis, please, from Finetech. So let us know what you can do in this sense.
Hello, so shall I share my slide?
Yeah, please.
Would
be great. You too.
Okay. Just let me know if you can see my screen.
All good.
Okay. Yeah, first of all, thank you, Optica, for hosting and putting together such a great group of technologies. It's always excellent to attend these events. So I'm Travis Scott. I'm here on behalf of Finetech. So at Finetech, we develop die bonding and die packaging equipment, as well as providing process development and solutions as a service. So what separates us from our competitors is our flexibility and our ability to offer a huge range of bonding technologies, all within the same system. And this is really excellent for R&D and development, but we can also transfer this out into production. So our systems are famous for extremely high accuracy for microassembly of very small electronic components, photonic components, or optoelectronic systems working together. We try to aim for very high yield and reproducibility to ensure that your products always come out exactly the same and every bond is always exactly the same at the end. And we like to work with customers to develop these solutions as a whole. So you don't just buy a machine, you buy a full running solution. And some examples for this that we have in the ophthalmology area. So we've worked with NIDEC in the just recently to develop this artificial retina for improving vision. We've done some projects with customers building these AR/VR contact lenses with extremely tiny micro LED displays, where we have to bond 0.5 millimeter by 0.5 millimeter chips using gold interconnect or indium interconnect. One example is polar light technologies for these micro LED displays going in that direction. And then finally, I asked a question earlier about BCI because we work with some companies, for example, Neuralink, where they're using a brain-computer interface to communicate with the camera to replace human vision by communicating directly into the brain. Yeah, and then our systems also build a wide range of other technologies like laser bars, transceiver technologies, all these other things in the background of other ophthalmology technologies and products. So yeah, if you have any questions, I'll be here at the end of the presentation and we can pick those up there. And again, thank you very much to the Optica team for hosting.
Thank you. Yeah, thank you so much. Thank you so much, Travis. So this is something that can help you, Alan.
Yeah, absolutely.
Absolutely. Okay, good. So, other people that you actually need to talk is to Laureline. Laureline, can you tell me what you can do for Optos?
We can help with the signal acquisition part after the photo detector, and we can help with the real-time processing and also to the size reduction. I understand that it's also important for the end product. So definitely, I think we can support the Silverstone platform, for instance.
You should talk definitively. And now is the time to bring to a very important point of the discussion. And we are going to see how AI is enabling this ophthalmology is not only a software question, but it starts with the image quality, the acquisition stability, the latency, the processing, and the data reliability. And I would like to bring a clinical precision medicine perspective to this program. And it's my pleasure to invite to the floor Nancy Achua from the Moore Shields Eyes Hospital of the NHS Foundation Trust and UCL Institute of Ophthalmology. Nancy, the floor and the attention is all yours.
Thank you, Elena. Thank you very much for the invitation. Let me share the slides.
Almost there.
Almost there. Can you see it?
Yes.
Okay.
Clear.
Let me just go back to the first one.
Yeah.
All righty. Yes. Yeah, it's always nice to start with a historical view of the inherited eye diseases. And this was the publication in the 1800s of the first retinal paintings showing RP. And I realized that it took them about 19 months of innovation of the first ophthalmoscope and ophthalmologists that had some artistic skills to be able to show this. And this is like the central image is retinitis pigmentosa, which has the typical showing of the pigment clumping disease, which affects the rods at the back of the eye, and patients cannot see at night and have tunnel vision. And unlike now, which everything happens with the push of a button, and you have a lovely Optos picture. The first, for retinitis pigmentosa, there are almost like 130 to 200 genes responsible for this phenotype. And the job of a retinal ophthalmologist in inherited disease is always like to figure out which panels to request in genetic testing. We have now whole genome sequencing, which can do 20,000 to 30,000 genes, analyzing them. And then for us, when the OCT came, of course, I always tell my patients it's like the ultrasound, but using light. I'm sure it's the very shortcut version of the OCT, but we are always interested in the cones and rods, which you can see, the ellipsoid zone and the retinal pigment epithelium, where most of the damage happens. And this is to show in 1899, ophthalmologists discovered like 4 sisters who had this phenotype, which we are now seeing with the imaging, with these whitish honeycomb appearance, and with the help of the autofluorescence. And later on, they discovered that this it's only one gene that can give this phenotype. And actually all the families in the world, whether in Switzerland or in the UK, when you look at this in the genetics clinic, you know exactly, you don't need even whole genome sequencing, you know which gene causes that, which mutation and where, and which exon. So we have moved quite far with all the imaging possibilities that we have. And for example, here you can see this is USH1C, so patients that have Usher syndromes, which affects their hearing and their retina, and give them this phenotype. You can see which ones, based on this imaging, on the left top side, for example, all this autofluorescence, all this area which is white, it's like the border, the boundary between the healthy and the unhealthy retina. And you can see on the top left, top right, the red arrows showing the area where we look at to see how much retina is still there. And while the picture under is showing that there's almost nothing left of their photoreceptors of the cones. And also with the imaging, we can see that, for example, if you look at this is a special type of retinitis pigmentosa. We call it sectorial, and you can only see these clumps at this boundaries, inferior. And just looking at that, you can know that it's only 5 or 6 genes which can cause this phenotype. So it has been it's quite helpful in this way as well, with the differentials, with the diagnosis, with the prognosis, with gene therapies, for example. This is one of the gene therapies which we, a few years ago, children who have retinal dystrophies that can become blind around the age of 4, for example, and they've had the gene therapy injected the back of the eye. And then you could follow up with the OCT, for example, their baseline from how much this ellipsoid zone was. And then 2-3 years later, you can see it on the right is the eye that was not treated. This ellipsoid zone almost disappeared. And on the left eye, it has been maintained, or it has even become larger 3-4 years down the road. And this was the machine which we used, the Bioptician, for example, to take those images for the children to do the OCT. Most of the time we had to do it while they were sleeping, actually, because, children is very difficult to focus. And this is a very small video. I won't play everything, but, oh, it's not playing. Let me see if I can. Well, it's supposed to show you the child who initially could only, like with a hand movement, trying to find where the things are. And then with those videos, I was hoping to show you. No, it's not working. Anyway, he could read the letters and see the cars, and it's like really incredible how much they have improved. So that was one of the great things that you can capture with imaging in inherited diseases. And this is also, for example, adaptive optics, which you can count the cones, and patients with achromatopsia, where it's almost the opposite of retinitis pigmentosa. Their cones are affected and they are very light sensitive and suffer from nystagmus, for example. And here you can see that you also need, with every imaging, to count. There might be different graders, of course, and you have to have the repeatability in imaging. And this is one of those pictures showing that, 2 graders. And this brings me to the summary of the talk. Most of our patients have low vision, or have nystagmus, or are visually blind, and it's very, very difficult. As you can see here, for example, we were trying to get adaptive optics for them, but they cannot focus. Their eyes move all the time. And quite often, we don't get proper imaging of people like that. And that's us trying to focus the picture. So my question would be for the Optica, and if it's, instead of the patient trying to focus on the machine, if there was any way that for this category of patients that the machine can follow the eyes and still get a proper OCT or a proper scan, which would be helpful with all the things that I have mentioned. And that's my story.
What a story, actually. Thank you so much. And you make a proper challenge. So it's really, can the photonics industry can make the imaging systems to follow the eye instead of the eye following the imaging system and get focused. So we are talking for something that is more dynamic. So who can help here? That's a good question. I mean, you really blow my mind, Nancy. Is one of the things. So for that, I will ask you one question. What is the how good have to be the imaging, like repeatability of the imaging when you are following these patients? Because this is one of the things. It's like is you are looking for changes, and you are looking for changes that they are very subtle. So what are your specifications for that?
Well, in clinical trials, mostly we get like, you can only use this strategy, you can only use this size of for example, with the OCT, whether it's 6 by 6 millimeters, or there are certain requirements so that you can assure that the repeatability is attainable. This is one part of the story. The other thing is, now, of course, with the coming of AI, it's a bit easier, but Are you asking from the perspective of the photographer, or are you asking from the perspective of the ophthalmologist grading the pictures?
Both.
Both. Yeah, I think photographers, it's very difficult for them when the patient has so many challenges. But if they follow the same strategy, I think the ophthalmologist has to make sure it's not an artifact and that what you are measuring is exactly on the same level. Like I think Professor Huang can say, you have so many levels that the eye is being scanned. So if you focus on the same one.
Yeah, that
It
makes
is,
sense.
yeah, it is prone to, artifacts or wrong measurements. So you have to be careful indeed.
Yeah, totally. So actually, Larry has a very good question. So Larry, can you please tell your question yourself? So Larry Benjamin from Orbis, which is one of our speakers invited, but he has a question now, and I love the question. Larry, could you please?
Yeah, I just wondered whether eye tracking would be useful for these patients. We obviously used in refractive lasers, and the retinal lasers for delivery of panretinal photocoagulation can use eye tracking as well. I don't know if that's sensitive enough for what you want. Would that be useful, perhaps?
I think it would be useful. I mean, most machines have a form of eye tracking because patients have, but the cooperation is required to focus on the cross, for example, when you are looking.
Right.
It would be extremely helpful if the machine can indeed rely on the eye tracking and take the scan.
Sure. Thank you.
Yeah. So someone that maybe can help here is a company that is called Modulite. They have medical and ophthalmic laser solutions, and the precision fibers don't stop at diagnostics. They just tend into targeted treatment. But I think maybe there is a good thing that they can do here. So Erika Sokas from Modulites, I would like to call you to the floor, and I would like to see first if you can help in this requirement that NAS is putting. This is quite a challenge, and also present Modulite and what you can do in general for the ophthalmology and the vision care. Erika, the floor and the attention is all yours.
Thank you, Helena. Hi, everyone. Indeed, my name is Erika Suokas, and I work as an application engineer here at Modulite. And we really appreciate the opportunity to present in this meeting today. So we prepared you some material about Modulite's laser solutions in ophthalmology. So we have ophthalmic laser platform called ML6710i. You can see the picture of it on the right-hand side lower corner. We call it ML6710i, and it's multi-indication platform, which is definitely a unique treatment solution in ophthalmology. It allows activation of different photosensitive drugs and also supports both configuring and managing the output per indication. In many cases, an ophthalmology department in hospital or a private practice has both retina specialists and ocular oncologists. And our technology allows the user select the drug and indication they're treating, resulting in controlled treatment parameters. This also creates a treatment record, which is essential not only in commercial treatments, but especially important in investigational use. So currently, the same platform is used in multiple clinical trials as well. So all this data is then stored in Modulite Cloud, and through Modulite Cloud, a trace between the used drug and realized treatment is generated, which also enables transparent and detailed cost allocation per patient, which is a really important factor as well. And this is the basis of Modulite pay-per-treatment. This simplified contractual service allows the hospitals to focus on their primary tasks, which is healthcare and not owning the equipment. And through pay-per-treatment, they do not need to worry about buying and managing the devices, only using them for the patients. So we really aim to make this as easy as possible for the hospitals and clinics so that they have all the equipment they need to treat the patients. But we really take care of the whole life cycle and management of this device. Would you have any questions at this point? I would be happy to answer those. That's all I have for today.
Yeah, many thanks, Erika. So this is again, I mean, we come back to the first question. What are the laser sources that we really need here? What is going to be the best? And it seems like with all the personalization and everything and different cases, this is not going to be a unique answer. It's going to be multiple choices for different things. So
Yeah,
that's
yeah.
yeah, that's one of the things. And I want to close the meeting with a very special guest that we are having here. So his name is Mr. Larry Benjamin. He's an Orbis ambassador and retired consultant of ophthalmology at the Stock Vanderbilt Hospital. Larry Bill brings a special global eye care perspective, and I want him to present himself. So Larry, please, I mean the floor and attention is yours. Please put attention to what he has to say. Is a mixture in between deployable, but is also a very good cause. So thank you so much for coming. Larry, you are mute. Can you mute yourself, please?
Or
You are still mute, Larry. So for any reason, you are mute, and this is not.
I thought I'd pressed it. Can you hear me now?
Okay, now I can hear you,
Great.
and
Thank you.
you are sharing the full screen, not the presentation. Okay, now we go.
Can you see my
Now it's
presentation
perfect.
now?
I can hear you.
Lovely.
I can see your presentation. Please, the floor and
Okay. Thank you very
attention
much.
is all yours.
Thank you very much. And thank you for asking me. And it's been a privilege throughout my working life to see the development of all these wonderful machines and to use them. So thank you to the industry for that. So we're going to talk about how in the developing world we can hopefully get better support for eye care. A little bit about Orbis. It's the only accredited flying eye hospital in the world. It's been flying missions since 1984, and it's on its third iteration of aeroplanes now. We started with a DC-8, which is an old airplane now, but is now an MD-10 with an MD-11 cockpit for those who are interested. But the purpose of saying that is that the plane has a longer range, fewer pilots, larger payload capacity, and can stay in a place for longer to run programs. So it's beneficial. There's a brief video I hopefully will show of the airplane itself and how it's been developed. And the important thing is this modular system. And you can see here one of the modules being loaded into the airplane. And it's these modules that are converted into the various clinics or operating rooms that the airplane uses. It takes a lot of paint to paint it. But once it's painted, you can see on this walkthrough, the first class section is now a teaching section. Then there's the clinic, which has the lasers and OCT machines and eye-size simulators for surgery. Next door to that is the operating theatre, which you can see here briefly. And then you can see the teddy bears we operate on. It's usually people in the recovery at the back. And so just a few more pictures of the airplane. This is the EyeSight indirect ophthalmoscope virtual reality simulator teaching system in one of the clinics. This is the operating theatre being used for, again, simulation teaching. And it has a 3D screen at the back in order that the operating staff can see the operations as well. So very high tech in terms of equipment. And that's just an artificial eye being operated on. Excuse me. Some pictures from a couple of programs I've done. I've often done programs without the airplane, which is much more challenging for Orbis. And this was deep in southern India in Sarigur. And the two girls standing in front of me are sisters. One of them has albinism, and because of the lack of pigment in her body, she can't see well because she has no pigment behind her retina and couldn't read very well. And so for the cost of $1. We gave her this magnifying aid, and she was able to read sentences for the first time at school in many years. So our help doesn't need to be expensive or high tech. It's just important to introduce the right sort of things. We use imaging a lot, as you've seen in all the previous talks, for screening, assessing, teaching. We have a 3D microscope where I used to work, and that's very good for teaching. Capturing videos for teaching, very important. And we also use a lot of our pictures for art, you'll see in a moment. Lots of images you've seen already, from the front of the eye to the back to CT and MRI scans. Imaging is absolutely critical for what we do. And again, we're all really grateful as practicing clinicians that there are so many intelligent people developing this equipment for us to use. This is an example of art. This is a picture that won a prize in a competition showing posterior capsular pacification after cataract surgery, and most people will be happy to hang that on their wall. The equipment, though, is often big and unwieldy, and everything costs $50,000 or above. So on the top left, you can see a fundus camera, a pentacam next to that. The only thing that's handheld anymore is the ophthalmoscope, which nobody uses anymore because we use lenses at the slit lamp. And on top right is the slit lamp, which is our standard instrument, and the Optos scanner at the bottom there. In the developing world, there's a huge problem with access, so patients getting to services and services to patients. That was one of the founding issues about Orbis was taking technology to people who don't have access to it. Funding is often an issue. Teaching and training is a big issue in terms of reaching the numbers of people that need it. And maintenance of equipment is surprisingly a bigger issue than you'd think. So sometimes, because of a broken fuse in a plug, a blown fuse in a plug, a piece of equipment will stand idle because nobody knows how to fix it. So it's quite important. So I'm going to give three brief examples, or three or four, of equipment that in the developing world needs to be slightly different, perhaps. Of course, every country will use the standard equipment that's available to everybody if they can afford it. And the slit lamp I've already shown you takes lovely pictures of the front of the eye if it's a photo slit lamp. But you can have a portable slit lamp. And I first saw this 50 years ago when I was a medical student in Papua New Guinea. You can see on the right of the picture there is a portable slit lamp, and this ophthalmologist is using it to screen for trachoma out in the jungle in Papua New Guinea. So that's been available a long time. The handheld ophthalmoscope often uses it combined with a retinoscope, you can see on the right, and uses mains current to power it. But here's an example of a handheld device. You can see on the right there, it's very tiny, fits into a case in the palm of your hand. This is solar powered or chargeable via USB-C, and is an ophthalmoscope which has sliding lenses at the top, which can allow to view the fundus in people with different refractive errors. It has a torch built in, it has a red spot for measuring visual fields, and is a multi-instrument and cost about $5. So this can be given to many people who are not necessarily doctors or nurses, and can be used for screening and monitoring. Fundus camera is big and heavy and expensive, but here's an example of a telephone. We used to call them telephones, an iPhone adapter or an Android phone adapter. You can see here just clips onto the phone and can produce retinal images, again, for the fraction of the cost of a big machine. And on the right, you can see a picture. It's also used for visual screening, for visual acuity testing with the so-called tumbling E test. These are not made anymore, unfortunately, but the technology exists and is available. It also has geolocation because it's a phone. So for finding patients again in remote areas of a country, it's very important and very useful. It'd be nice if that were built into more devices. This is an example of a laser. When I first started at Stoke Mandeville Hospital in 1990, this was a tunable dye laser, which we had for some reason. I've never worked out how we got the money for it. But the cabinet is 5 feet long, and nowadays the solid state lasers fit onto the table next to it, and the laser on the right there has three lasers in one. They're very portable and can be taken out into the country or into operating theatres and used in a number of different ways. So reducing the size and weight and often cost of these things has been a great issue for developing countries. We use a system called CyberSight, which is an online learning platform, and that enables us to reach people around the world. Pre-COVID, we had 5,000 registered users, and post-COVID, it went to 150,000, because for some people, it was the only way they had access to teaching and learning. And it allows remote consultations across the world. So, I can give an opinion about a patient in Zambia or Cameroon, and it also allows us to assess patients online before the Flying Eye Hospital and the team arrives to actually do surgery. And it's very useful for seminars and webinars. A few slides about cases I've seen. So this young lady, bilateral cataracts at the age of 5, completely blind, couldn't go to school, couldn't see her mum. This is her waiting for cataract surgery. And post-operatively, she was extremely pleased because not only could she see, but she could count her M&Ms, which is clearly important. And this is one of the issues. You allow children to have a normal childhood rather than, living in a poor place, but also being blind is a very trying issue, as I'm sure you can understand. Here's Joseph, who lived in a village in Tanzania. You can see the clock on the wall behind him is backwards, because upside down rather. He didn't know that because he was blind from cataract. He was the village cobbler, and he hadn't been able to work for 3 or 4 years because of cataract. He couldn't see a hand waving in front of his face. This is him about to undergo his second cataract operation. And afterwards, he was very pleased. He said, "Oh, I'm so handsome, I'll have no trouble finding a wife now." But in addition, he was able to go back to work and mend people's shoes, which meant they could go back to work. So the impact of curing one person's blindness can have wide-reaching effects across the population. So in summary, the Flying Eye enables access to eye care for poorly served populations. We try and make sustainable programs that last 3 to 5 years and teach local surgeons to teach their own surgeons later on. And it facilitates advocacy in developing countries, and it's a great training environment for the local surgeons. And in terms of equipment, it's useful to have cost-effective portable equipment that's good enough. The quality is good enough to make the diagnosis and to monitor things, but also has to be reliable and maintainable. And please consider solar power and geolocation. Thank you very much. A very brief summary of what we do with Orbis.
Thank you. Thank you so much. It is so great to have this presentation closing this event, and makes us realize how important it is to really make the best of the technology to make the world a better place. Larry, it's a clear question. We have the whole power of the Optica network. Many people are going to see this presentation on demand now. Many people are in the room right now with us, from investors to technology suppliers. How can we help you?
Well, it's difficult, isn't it? Because, companies are there to survive, have to make a profit to do that. And one of the big issues in developing countries is there's no money. And if there is money, there's often corruption. And so the money doesn't get where it's needed. So, we often do buy expensive equipment because that's what's available. But as I showed, there are examples where smaller, cheaper, lighter equipment can do a similar job that can be good enough. So, working on those sort of instruments is fantastic. And if people can come up with smaller lasers, cheaper lasers, that's fantastic. And it's happening. We've seen it happening over the years. And I think the industry has seen that is a way forward. Although the funding is less in terms of total amount of money available, the reach and I suppose the market is massive. The developing world has a huge market. So in terms of, you could stack them high and sell them cheap rather than making a few and selling them expensive. I suppose that's one issue. So development of instrumentation that is workable and cheaper would be a huge help.
I just have to look at the faces of people in the room right now to realize how important was to hear this presentation from you. For all of you, if you want to get in touch with any of the participants today, all you have to do is to send Helena or me an email and we'll make the introduction. That's what we do for a living. It has been great to share the last 2 hours with you. One of the most exciting and entertaining events I have been in a long time. Thank you. Thank you so much.
This is Optica. This is lighting redefined.
Okay, so please allow me to ask my IT department to switch off the live stream, to disconnect the live stream. I want to have 1 minute private with my friends here. Well,